for example, let's look at the episodic vertigo. So if it's episodic, can you trigger it? Can you make it happen? And that would be your Dix-Hallpike, where you test them for crystals, right? So you have them turn their head, lie down, does the room spin around or not, check the other ear, and then lift their head with them in supine and turn their head left and right for the lateral canals. If yes, that causes nystagmus and it causes dizziness, then we say they have BPPV. If it doesn't trigger nystagmus and they say that those motions bother them, they still may have BPPV. So when crystals come loose, we usually tell people you have a crystal that came loose. What we mean is you have a bunch of crystals that came loose, because they come out in bunches of 60 or 80 that are rolling around at once. And the maneuvers are designed to put them back where they belong, and hopefully they stick down and stay there again. But I woke up at 2 in the morning. Did I tell you this story? Or was that in a personal conversation? So I woke up at 2 in the morning because the room started spinning around because I rolled over in bed. Did I tell that story? All right. So at first I had nystagmus. And so I did a maneuver. I kept trying maneuvers. And eventually I didn't have nystagmus, but I still felt nauseous and dizzy every time I laid down. Why? Because I still had crystals loose. There weren't enough to trigger a motor movement, but it was enough for me to sense. I could feel it. And it was very uncomfortable feeling. And I was worried that I was going to be stuck with it because it lasted for months and before it finally went away. So just because they don't have nystagmus does not mean they don't have crystals loose. So what do? You treat them for a crystal and see if it goes away. Because in most cases, when you do a maneuver, 1 or 2 maneuvers, they're fixed. In most cases. Now, sometimes it takes longer. But in most cases, in 1 or 2 tries, you got them fixed. If the Dix-Hallpike is negative, meaning there are no nystagmus and they don't get dizzy, then you check them for orthostatic hypotension. But I have a problem with this, because when do you get orthostatic? When you're lying down or sitting up? When you're sitting up. So are they going to get orthostatic when you lie them down? No, they're not. Right? So that's where your questioning comes in. When they say, I get dizzy when I get out of bed, your very next question should be, what happens when you lie down? What happens when you roll over? And if the answer is, oh, I can't do that because I get really dizzy, well, then you start looking for a crystal. All right, so if it's episodic, means it comes and goes, and it's spontaneous, meaning you can't trigger it, it just happens on its own. If there's hearing loss involved, then you want them to go see someone and look into Meniere's disease. Now, there's no one test that can tell you if you have Meniere's disease. So there's an audiology test that they do that kind of hint toward it. Really, it's the person's history. And it's episodic vertigo attacks. They last for up to like 2 hours or so. And they're usually very, very bad. They end up in the hospital to be sedated. And that's all you can really do for them is sedate them, because you can't stop it. There are treatments for it. There's a machine called the Meniette device, and it pumps air against the eardrum, and that distributes fluid in the vestibular system, and that reduces some people's symptoms. But there's no treatment for the disease itself. It's progressive disease. If it's spontaneous and it coincides with a headache or a history of migraine, then you start looking into vestibular migraine. Vestibular migraines do exist. So my best friend is one of these cases. He came to me and he says, I'm dizzy, can you examine me? And I did a thorough examination, but I couldn't find anything. But I know he has daily migraines. And I said, well, what do you take for your migraines? He said, Advil. I'm like, oh my gosh, you're frying your liver. You can't do that. So I got him set up with a neurologist. They put him on medications, and it helped a little bit. And then I read an article on Botox. And I said, well, did you ask him about Botox? Well, he doesn't do Botox. What should I do? Find another neurologist. So we found another neurologist who would do Botox, dramatically decreased his dizziness. And he wasn't getting dizzy with a migraine. He would have dizziness or have a migraine. They were never together. But after the Botox, now his dizziness immediately precedes a headache. And it's not as bad, and it doesn't last as long. It's the migraine. All right? So it was vestibular migraine. So if there's a history of migraine, suspect migraine as a possible cause. Again, psychiatric issues. Are they panicking? Is there something going on in their life right now that's upsetting to them? Do they have a psych history? You can just look at their medication list and figure that out. All right, so continuous dizziness. Is it associated with traumas, toxins, or is it spontaneous? So traumas would be like barotrauma. So this is your typical 90-year-old who just got back from diving, right, or skydiving. Right? So basically anybody that has a barotrauma, right? So they're diving, they were recently got off an airplane and now they're dizzy. You want to check them for fistulas. Where am I? Barotrauma. And then medications. So I'm continuously dizzy. But, you know, I just recently had an orthopedic surgery and they had me on aminoglycosides. It's probably what caused it, right? So you have to send them for tests, send them to the audiologist to do inner ear tests. All right, and then we have our HINTS exam, which we're going to learn. And so this is saying that if saccades are present and unidirectional, you have horizontal nystagmus, normal tests of Skew is probably vestibular neuritis. If you don't have any saccades, nystagmus are dominantly vertical, torsional, or gaze-evoked bidirectional, means directional changing nystagmus, it's probably a stroke. So we'll go over that in more depth. It's easier to understand on another slide. Yes?
Can you go back, please?
Sure.
Can I suggest an addition to that?
Sure.
Is it triggered?
Well, first of all, this isn't my chart. This came from this article. All right, so this was published in 2017 in Family Physician Journal.
Well, for the sake of...
But yeah, we can improve on it. So.